Thanks to everyone for joining this month's Pepper Rounds. I'm pleased to introduce Dr. Leis. Dr. Leis is a research assistant professor in the Department of Epidemiology at the University of Michigan School of Public Health. Dr. Leis's research centers on inflammatory pathways, including the etiologic intersections of chronic and infectious disease, and their synergistic effects within a particular focus on non-traditional risk pathways for the development of metabolic and other chronic diseases across the life course to inform prevention strategies. Given the major impact of viral disease on the health of populations and the potential for long-term implications, she's particularly interested in the impact of post-viral infection health on the inflammatory landscape and its relation to the development of cardiometabolic and other chronic diseases. She also studies the relationship between metabolic health and adverse cardiovascular, physical, and cognitive health outcomes. Dr. Leis has over a decade of experience working with large, complex data sources, including electronic health record databases, longitudinal cohort studies such as the NIA-funded study of women's health across the nation, and CDC initiatives for acute viral respiratory disease surveillance. She received an MS in Biostatistics in 2015 from Drexel University and her PhD in Epidemiologic Science from the University of Michigan in 2022. So Dr. Leis, I will let you take it away.
Yes, thank you very much for that introduction. Okay, I believe everyone should be able to see my slides. Wonderful, thank you so much. And thank you so much again for the opportunity to present here today. Before I start, I have no disclosures to report. As I'm sure many of us in the Zoom room are aware, diabetes is a very significant health outcome and consequence that is quite prevalent both in the United States and globally. Based on data from 2021, there are approximately 38.1 million adults with diabetes and an additional almost 100 million adults with pre-diabetes on top of that. So here, pre-diabetes is defined as a fasting glucose value of 100 to 125 milligrams per deciliter, or an A1C of 5.7 to 6.4%, where diabetes is a glucose then of greater than 125, or an A1C greater than 6 or greater than or equal to 6.5. As you can see in the figure on the right, there's been a general uptick in both the prevalence of diabetes and prediabetes over the last 10 to 15 years. It's also important to note that the prevalence of both of these conditions is higher in racial ethnic minority groups. Diabetes in particular impacts adults of older age disproportionately. This figure here shows how the proportion of diabetes increases with age. So after the early young adulthood to age 45 or so, there's a fairly low prevalence of diabetes. But then once you enter that midlife period, age 45 to 64, there's a very significant, almost tripling in the prevalence of diabetes. And then there's another almost doubling of that prevalence for those age 65 and older. There's additionally, for most of the life course, similar prevalences between men and women, although in that older age group, greater than or equal to 75 years of age, men do have a slightly higher prevalence than women. Additionally, diabetes as a whole results in about $400 billion or more in annual healthcare expenditures per year. This includes both direct medical costs, which account for about 3/4 of that, and then indirect costs such as lost productivity. To put that $400 billion into perspective, that's about 8% of total US healthcare expenditures. And additionally, people with diabetes account for about 1 of every 4 healthcare dollars spent. It's important to note as well that despite these very high numbers that we are seeing with the prevalence of both prediabetes and diabetes, data from the National Diabetes Statistics Report compiled by the CDC shows that there's actually significant numbers of individuals within the population who don't know they have these conditions. So focusing first on that figure on the left for the rate of prediabetes, the bar itself is the total prevalence The orange on the bottom is those who are aware that they have prediabetes, and then that yellow is those who are unaware that they have prediabetes. And if you kind of note the distributions of those bars, quite a significant number of individuals are unaware that they have prediabetes. Although moving closer to the present time, that proportion has gotten much closer to about half, which is still quite problematic given what we know about the potential consequences of hyperglycemia. There's a few different reasons why these individuals might not be aware that they have prediabetes. Some of it is likely due to a lack of testing. And then also a number of individuals have indicated that they don't know that prediabetes is a thing that they should be aware of. And finally, oftentimes in certain clinical settings, especially with younger adults, if that glucose pops up as greater than 100, but not just above that threshold, the clinician might not have that conversation with the patient about prediabetes. So given this prevalence, as well as we know that there are changes in diabetes prevalence as a whole across the life course, there are still critical gaps in understanding how having an impaired glucose metabolism, so particularly that pre-diabetic state or even that diabetic state across the life course, particularly in women, impacts development of adverse outcomes in early older adulthood. Women in particular are at unique risk for development of cardiometabolic diseases in particular due to the menopausal transition. So very briefly, to define the menopausal transition, since this will be the focus of a good chunk of this research. So perimenopause in women begins around age 42 to 46. And in some women, especially those with chronic disease or autoimmune conditions, which do happen more often in women, can have an even earlier start to this perimenopausal period. During this time, that's when the menses become irregular. They'll start to see a general decline in estrogen levels, followed by a lot of symptoms that I think some of us are familiar with, including hot flashes, insomnia, and in general, physiologic changes. Following the perimenopausal period, the last menstrual period generally occurs around age 50 to 51. And then menopause is defined as the 12-month, that 12 months following the last menstrual period is when menopause begins. As you can see, there's then, there's obviously a lot of life that happens in women beyond menopause. And given that they're at potentially increased risk for a lot of these factors, many women have then 20, 30, 40 years of being in this increased risk state due to that loss of estrogen. During the menopausal transition, there are significant metabolic and physiologic changes that occur. Some of these are highlighted here in this figure. So there's generally an increase of comorbidities, increase in depression, along with decrease in muscle mass and decrease in energy expenditure. All of this combined can result in an increase in body weight. However, it's important to note that women who undergo menopause experience these changes regardless of their body size. Additionally, sorry, the Zoom box is in the way. Additionally, directly as a result of this decline in estrogen, which we know is so protective against so many cardiometabolic and physiologic consequences, there is direct action on how insulin in particular is metabolized within the body. So as previously mentioned, also that decrease in muscle mass can change how your body uses insulin. There's also an increase seen in triglycerides, potential increase in chronic inflammation, and potential decreased insulin signaling. All of these changes, in addition to potential decrease in insulin secretion, can set women up to really be at a super increased risk for insulin resistance, which then can lead to type 2 diabetes. And in particular, it's important to note that during this time across the midlife, again, this is ages like 40, mid-40s to mid-60s, mid-50s, there are both aging and hormonal related changes, particularly to muscle mass, that doesn't help with these factors. And finally, we know that menopause itself can increase the risk of cardiometabolic diseases, including an impaired glucose metabolism and other cardiovascular diseases. In particular, having an earlier age at menopause, as well as certain symptoms, vasomotor symptoms in particular, things like hot flashes, as well as having more severe menopausal symptoms, are known to be associated with this later development of cardiometabolic disease. And this is all important because regardless of the cause, we know that there are many consequences of hyperglycemia. This figure here shows some of the traditional complications that I think we're all pretty familiar with. Diabetic kidney disease, stroke, peripheral vascular disease, retinopathy. However, now that people are both living longer and there are better treatments and management for those with type 2 diabetes, as well as type 1 diabetes, we're now coming into an age where there are a number of individuals who are living well into older adulthood with diabetes and potentially with hyperglycemia if it's not as well treated. And this then leads to a new set of now they're finding emerging complications related to hyperglycemia. A lot of these are previously thought to be specifically related to aging, and we obviously a lot of research currently is trying to figure out what are some risk factors and preventative factors for some of these. So having hyperglycemia in particular can put you at increased risk of certain cancers, obviously infections, liver disease, and then also cognitive disability and functional disability. Despite all of what is known currently in the field about diabetes in particular and hyperglycemia at a diabetic level, the prediabetes level and overall impaired glucose metabolism, so those just any glucose greater than 100, has been significantly understudied in these areas. The goal of the current study that I'll be presenting here today is to examine that impaired glucose state across the life course for two of these emerging complications, functional disability and cognitive disability. It's interesting to note that in regards to the cognitive disability in particular, the prevalence of mild cognitive impairment in individuals with type 2 diabetes was similar in those less than 60 and greater than 60 years of age, which is different than what's seen in the general population, where the prevalence of mild cognitive impairment increases with age. So the data that I'll be presenting here today comes from the Study of Women's Health Across the Nation, or SWAN. SWAN is uniquely positioned to answer these questions about changes in metabolism and glucose metabolism in particular across the menopausal transition and into early older adulthood. SWAN is a community-based, multi-center, multi-ethnic longitudinal study that's been funded by the NIA for a number of years. Women were recruited in 1996 at ages 42 to 52, so just in that early perimenopause, or even in some cases, fully premenopausal, and then followed through to the present on semi-annual visits. So there are currently about 17 visits in SWAN. Each of the 7 study sites, which are represented here in the yellow arrows, had an ethnic minority recruitment strategy of either African American, Chinese, or Japanese women to help increase the generalizability of this data. So this figure here shows the data collection methods specifically for the key variables that I'm going to be presenting for my analysis. In general, the long horizontal lines show the time span over which these data were captured. The downward facing arrows specify the individual time points from which I'm pulling for my current study. And then at the bottom of this figure, you can see what the visit numbers are, as well as the years that the data was collected. So there's, almost 30 years worth of data represented here. So in terms of the glucose exposure variable of interest, hemoglobin A1C was not collected at all sites. So we're using fasting glucose to measure our primary exposure. And that was collected at 11 visits across the study period, which are again represented here by these downward arrows. Cognitive function testing began in SWAN in visit 4. And we're using visit 7 as the premenopausal baseline measure to account for the learning effect of some of these cognitive measures. And then the outcomes for this study will be taken from visit 15 and visit 16, or sorry, visit 15 and visit 17 for cognitive function. Physical functioning measures in SWAN, including grip strength, began after menopause for a majority. The vast majority of women in SWAN were already postmenopausal by that visit 12 time point. So we unfortunately don't have a good premenopausal baseline to adjust for. But again, we'll be taking the outcomes from visit 15 and visit 16. This box just highlights here where those visits are in the timeline, and we'll also be measuring the change between these two visits as a third outcome time point for each of these. So the exposure of interest is the number of years spent in an impaired glucose state. And to our knowledge, this is the first time that a variable like this has been computed within the SWAN cohort. We computed this as the number of years in an impaired glucose state, defined as a fasting glucose greater than 100 milligrams per deciliter. This value was chosen because that is the threshold for prediabetes. It's important to note that this does also include all diabetic glucose values greater than 100. However, it is possible that if diabetics are within our cohort who are very well controlled and have that fasting glucose less than 100, they would be considered as part of the normal glycemic group. That was by design because we were interested in the physiologic impact of the hyperglycemia itself. This information was computed from baseline through visit 15, again, across those 11 visits that had fasting glucose based on the time between clinic dates. The women were required to have either baseline or visit 1, and then on the other end required to have either visit 13 or visit 15 with glucose data. And then if there was a switch in time, so from normal glycemia to this impaired glucose state, we contributed half of the time towards an impaired glucose state. We also accounted for the total person time in SWAN, and we did find that many women did remain largely consistent across time between either normal glycemia or if they switched into an impaired glucose state, they then largely remained within that impaired glucose state. We also did impute missing data where possible. SWAN has, in general, a pretty low attrition rate, but from visit to visit, there's always some reason that some women weren't able to come into the clinic to give that blood draw. So we had 3 specific missingness categories that we focused on based on what we found in the data. If the status, the impaired glucose status or normal glycemia was the same on both sides of the missingness, we imputed to whatever that status was. If there was a switch, we would contribute half the time in that missing gap toward an impaired glucose state. And then finally, for the kind of NCAP time points, if an individual was missing baseline, those values were imputed from visit 1, given how close baseline and visit 1 occurred. For visit 15, we only imputed that from visit 13 if there were consistent trends in the prior visits just before visit 15. Otherwise, that woman was censored at visit 13. I know all of this is a little bit confusing, so I'm going to walk through a brief example of how these data were calculated. So briefly here, back to our timeline from before, you can see on the bottom the sample year that this sample woman came into the clinic for each of her SWAN visits. The N's represent glucose less than 100 milligrams per deciliter. The I's represent samples where that glucose was greater than 100, and that the X that's highlighted represents where there is potentially missing data. So here, starting at baseline for this woman, that baseline data is missing. Since the visit 1 time point is normoglycemic, we considered baseline to also be normoglycemic. You can see between visit 5 and visit 9, which is approximately 4 years in time, there were 2 missing visits, and there's a switch from normoglycemia to an impaired glucose state. So half of that time, or approximately 2 years, was contributed towards that time in an impaired glucose state. And then finally on the end, since the woman was consistently in an impaired glucose state for the years before visit 15, that was also imputed to be an impaired glucose state. So in total, that accounts for, if you add it up, about 12 years in an impaired glucose state for this woman. Our primary measure of physical function for this analysis is grip strength, which is a proxy for overall physical functioning in older adults, and it's an important measure of potential frailty. We also know that grip strength itself is predictive of cardiometabolic health. So there's a bidirectional relationship going on here, of which we're measuring the direction where the cardiometabolic health influences the grip strength. Specifically, our measure of grip strength we'll be looking at here is muscle quality, which is the average grip strength adjusted for the kilograms whole body skeletal muscle mass, which in SWAN is measured using bioelectrical impedance. Our measure of cognitive function that I'll be focusing on is processing speed. Decreased processing speed is a marker of cognitive aging, and is one of the earliest signs of cognitive aging and cognitive decline. In SWAN, this was measured using the symbol-digit modalities test, shown here on the right. Basically, the women have the key along the top, and then they're supposed to fill in the numbers that represent each of the symbols shown. Women are given 90 seconds to correctly match up to a maximum of 110 symbols. We then normalize these values to a mean of 0 and standard deviation of 1 to help aid in interpretation. For statistical analysis, we looked at multivariable linear models for outcomes at visit 15 and visit 17, as well as the change between time points. And that change, as you might have seen on the timeline, is approximately 6 to 7 years based on when the women came into clinic. Again, our exposure is this time spent in an impaired glucose state in years, and we also adjusted for the total person time included. We ran 2 separate models, or 2 separate sets of covariates based on the model and relevant factors. So for muscle quality, we adjusted for age, race, ethnicity, hormone therapy, total physical activity, whether or not they ever used an anti-diabetic medication, and height. For the symbol-digit modalities test, everything above that thick black line is the same. Then we also adjusted for their baseline from visit 7, BMI, education, and then as the test itself is reliant on eyesight, we also adjusted for the self-reported poor or good eyesight of the woman. The stars on these variables represent that we used either the visit 15 or visit 17 values as appropriate. And then models looking at change between visit 15 to 17 were adjusted for those later time point covariates. Since we did impute data, I felt it was important to show you that the amount of data that was imputed was quite small. In particular, there was a fair number of missingness at baseline that accounted for about 3 to 4%. We also had very, very few women that had a gap greater than 6 years between non-missing data points. And then about 2 to 3% of women had visit 15 imputed. So I had on my previous slide that the total SWAN population was 3,302. Obviously, as time progresses, there's a potential loss of individuals either for the study as a whole, or what happens more often in SWAN, they start to participate more in the self-reported data measures, and they become less often coming into the clinic. So here you can see how I arrived at my final sample sizes for the 2 different analyses that were run. At the very end, in order to be in the final analytic cohort, we did limit this presentation to those who had data at both visit 15 and visit 17, given one of the things we were interested in was that change over the 6 to 7 years. So starting with muscle quality, the age presented here is at visit 15. So the start of these muscle quality data, the women have an average age of 65, which puts them right at the beginning of that early older adulthood period. You can see a nice distribution of race and ethnicity. The mean BMI is just under that threshold for obesity for Black and white women. And then approximately 15% of the cohort ever used an anti-diabetic medication, and about 45% had any time in an impaired glucose state. Of those with any time in an impaired glucose state, the average time spent was about 8.4 years, and only about 30% of those individuals had any fasting glucose in that diabetic range. The mean and standard deviation of muscle quality by any impaired glucose state status is shown here, with no time in an impaired glucose state shown on the left and any time shown on the right. As you can see, there are pretty meaningful differences, particularly between those values at visit 15 and also at visit 17, with those at any time in an impaired glucose state having lower muscle quality values. The data shown here are the model results for unadjusted models, so just that impaired glucose state variable against the outcomes at the specified time points, and then at the bottom, the adjusted models. You can see there is attenuation of the effects with adjustment for those covariates. And it's important to note as well that these values do seem small on this x-axis, but they can be quite a meaningful difference as you scale up the number of years in an impaired glucose state, given how small the magnitude of the actual muscle quality values are themselves. I also wanted to highlight that we did find that there was no statistically significant difference for time spent in an impaired glucose state for visit 17, and also that change between visit 15 and 17. This does, given the information for visit 15, showing that those with more time in an impaired glucose state have lower visit 15 muscle quality. This as a whole suggests that those with an impaired glucose state might be a bit lower in their muscle quality values, but then we're not really seeing that difference in the change. And we wanted to dig a little more into this because we suspected that much of this might be due to the natural trajectory of muscle quality, so grip strength and skeletal muscle mass over time. Within the Michigan SWAN cohort, so a subset of that, this larger cohort that was analyzed, grip strength and skeletal muscle mass actually started at baseline rather than at visit 12. So that gave us the opportunity to look at trajectories of grip strength skeletal muscle mass, and muscle quality over time. The data presented here are stratified by whether or not there was any time in an impaired glucose state. And it's interesting to note that this dashed line is right at age 65, which again is the average age of our cohort. You can see that, especially in terms of grip strength, most of the women by age 65, that population average has lost about 20% of their grip strength, while the skeletal muscle mass also has a slight decline that isn't quite as strong. However, since the muscle quality then is a ratio of the grip strength to the skeletal muscle mass, a lot of those changes then of the individual components get kind of washed out in the creation of that ratio. However, you can see here in this figure that the trends across time and those women with any time in an impaired glucose state, that blue line, are starting way lower in terms of muscle quality. And then once they decline, they don't have quite as far possible to decline compared to those with any time or without any time in an impaired glucose state. The single digit modalities test cohort was largely similar. There were more women that had this data than the physical functioning testing, including Japanese women from one of the California sites who additionally participated in this across visit 15 and 17. The rest of the cohort descriptors remain largely the same, with a slightly lower percentage of those with any fasting glucose greater than 126 in that time in an impaired glucose state variable. So again, we normalized the single digit modalities test to a mean of 0 and a standard deviation of 1. So whenever you're looking at this table of the univariate results, values closer to 0 indicate that they're closer to that population center. And values further away are then farther away from that population center. So you can see pretty significant differences at visit 15 and visit 17 between those with any time in an impaired glucose state and those without, with those having any time in an impaired glucose state having pretty significantly lower mean normalized scores. The model results shown here, again, are structured the same, with the unadjusted results on the top and the adjusted model results on the bottom. We found it interesting that after adjustment, most of that difference that was seen at visit 15 does become attenuated. However, there's then a moderately attenuated results for visit 17, but then a pretty significant increase in the magnitude of results for the change. And in particular, I want to note that from what we know already about cognitive aging, most early age-related changes in cognitive functioning are just beginning to be seen in the 65 to 70-ish age range. So this significantly negative result, put this into context, someone with 5 years in an impaired glucose state would have a 0.1 decrease in their normalized score, which, given, again, the ranges of the score, is quite significant. So these results together suggest that not only are those who in an impaired glucose state kind of entering this late life period in a slightly decline or slightly lower processing speed than those without, they're also experiencing significantly sharper decline in processing speed over time in a relatively short period of time. Again, there's only about 6 years between visit 15 and visit 17. So in summary, we found that more time spent in an impaired glucose state across the midlife and menopausal transition into early older adulthood was associated with worse muscle and cognitive outcomes in these women. Muscle quality was overall lower for those with more time in an impaired glucose state, And while change remained constant regardless of the IGS status, we believe that this is due to earlier decline, which unfortunately was not measured in the full SWAN cohort. We also found that our cognitive change was impacted more at visit 17, with greater decline with more time in an impaired glucose state. So as a whole, this kind of boils down to, we saw different temporal effects of the time spent in an impaired glucose state between physical and cognitive outcomes in early older adulthood in women. So what does this mean? Understanding the early phases of impaired glucose metabolism, I think we all accept and know that that's important for identifying the ideal timing of interventions. As we found here, and then as other research has shown, even non-diabetic elevated glucose levels may cause harm, particularly if those levels persist over time. The American Diabetes Association recommends screening of everyone 35 and older every 3 years for prediabetes. And then they additionally recommend screening those with prediabetes yearly to look for progression to diabetes. However, if you remember the data that was presented at the very beginning, there's about 20% of those with diabetes and almost 50% of those with prediabetes who are unaware that they have the condition. This either means that screening isn't occurring as often as it should, or that these results aren't being properly conveyed to individuals for a number of different reasons. But this in combination with some of the results shown here really highlight that it's especially important to regularly test for impaired glucose metabolism across the midlife, particularly in women as they undergo the menopausal transition. Additionally, I think everyone here can appreciate a good baseline capture to fully understand a trajectory. However, baseline measures of function and cognition are rarely, if ever, captured in the midlife period. This is really important because by the time individuals do start to be screened for things such as frailty or loss of cognitive function, they might have already lost a significant amount of their functioning. And so then that change isn't seen, similar to what we saw in the muscle quality results from visit 15 to 17. It's also important to note that a lot of clinical decision-making relies upon cut points. So for example, the frailty grip strength cutoffs for women are generally 15 to 20 kilograms, depending on which guidelines you look at. But by the time women reach that cut point, many will have lost a significant amount of muscle mass. And again, re-showing that figure from before in the Michigan SWAN women, they've lost about a 20% overall decrease in grip strength before the age of 65. There's also no current recommendations for screening of cognitive function in asymptomatic individuals, which makes it also more challenging to try to catch these changes as they occur in older adulthood, but also any changes from what they might have been experiencing within the midlife. As a whole, there are no recommendations for cognitive or physical changes over the life course, but having these values could help inform the physiology of why we're seeing changes in older adulthood. And then finally, I just wanted to highlight that now we are also seeing a significant uptake of the GLP-1, glucagon-like peptide-1 receptor agonist to treat obesity in addition to diabetes in recent years. This is happening particularly among those who are in the midlife currently. Anyone who's worked around weight loss knows that any significant loss of weight results in a loss of muscle mass in addition to fat mass. And for certain individuals, there's research to suggest that certain individuals may then be at higher risk for sarcopenia if the muscle loss isn't mitigated with use of these medications. However, there has been some very early research particularly within basic science labs that are showing that these GLP-1 agonists might actually benefit cognition. However, they haven't been around long enough and being used in long enough across the life course to get a full grip of the full effects of these medications. However, these will play a very interesting role, I think, moving forward. And I am interested to see how they impact some of the results that have been previously published. So as a whole, to kind of summarize the big takeaway, there needs to be a holistic person-centered approach to help identify and treat prediabetes and impaired glucose state across the life course, particularly among midlife women. This is where health communication really comes into play with tailored conversation and shared decision-making to help women be able to move through the midlife with as reduced risks as possible, given the hormonal and physiologic changes that are going to occur regardless of what you do. I'd like to just take a moment to briefly acknowledge my collaborators on this project, both from the University of Michigan and also external collaborators from the SWAN study. I'd also like to thank the women of SWAN who have participated so enthusiastically over the years, and without whom I wouldn't have the data to present here today. Thank you very much for your time.
Thank you for that excellent talk. I invite everyone to put any questions in the chat. Dr. Linder, I'm not sure if we're able to unmute you, so you might have to put your question in the chat.
Let's see. Can you hear me?
Oh, yes, there you go.
Okay, great. Let me put my hand down here. And actually, that was a great talk. Thank you so much. We confront this all the time, of course. And maybe can you go back to, I realize my questions are all going to back up to your modeling choices. Can you go back to the slide about how you modeled covariates? Is Dr. Leis frozen? Sarah, you can hear me, right?
Yeah, she's frozen. Yeah, I think
okay,
she's frozen.
Perfect.
So I'm not sure what you.
Let's see if she'll be back.
Yeah, I think she just froze for a minute.
Yeah, I mean, I guess just for the group while we're waiting for her, I mean, my questions were about a little bit about, the choice of modeling impaired fasting glucose. As I understand it, the over time is really new, but it was interesting that it's just dichotomous, right? You just have impaired glucose, and the main model doesn't account for the degree of, here she comes back again. And so I'll ask her the question.
Hi, Dr. Lee. I don't know if you're able to unmute, actually, Eleanor, I'm not sure if you're able to unmute Dr. Leis.
Hi, I am so sorry. My computer just like blue screened of death at me.
It happens to everybody.
Yeah.
Perfect timing, but
are you able to hear me
out
okay?
of the questions,
Yeah. Are you able to hear me okay?
yes.
Okay. So I was going to ask, like, slides aside, I don't know if you're now calling in. Oh no, you appear to be.
I pulled out my emergency laptop.
Okay, super. Don't worry about the slides, but I was going to ask sort of a modeling question. Like, your choice of modeling impaired fasting glucose is sort of dichotomous, right? So I get that you're integrating the presence of impaired fasting glucose over time, but not accounting for the level of impaired fasting glucose. Is that right?
Yes.
And why not? Why not model that as well? And of course, you're going to wind up capturing a lot of people who have frank diabetes, or you'd have to do something weird with constraining, like, impaired fasting glucose, but exclude those with frank diabetes. But like, why that choice to dichotomize?
Yes, so we did, I'm sorry if it wasn't clear, we did look at total number of years as the outcome in the model.
Right.
But Yes, to your point, we are actually, that's kind of the next step paper building off of this one is going to be looking at some time weighted average type modeling, looking at what is the magnitude in addition to that time, and is there a threshold at which the magnitude matters, or is
Right.
it yeah, so that's a follow-up study that we're hoping to do within this cohort.
Right. The other question I was tempted to ask that's almost the opposite of what I just asked is, how do you know it's not just sort of outliers who have like, and it couldn't be degree of impaired fasting glucose, but you just sort of worry like there's outliers who have like really horrendous glucose control, horrendous cognition, horrendous physical function that's driving your findings. But that actually probably wouldn't happen here unless it was something about, long duration of time. So you might wind up confronting, but you'll get that in some measure of variability.
Yeah, and I will say, ironically, since this is a longitudinal cohort study, one of the biggest issues with longitudinal cohort studies is that the people who fall off are often those sickest individuals.
Exactly.
And so since they had to be in the study for now 30 some years, there is some sort of survival bias there with who we are seeing. But we definitely have some planned sensitivity analyses to look at some of those, 1%, 5% outliers for the physical and cognitive functioning, and also for the impaired glucose state, to just see how that removing them might change our results.
And then I guess one other question, and others, if you're able to raise hands, I think hopefully people can. I may have co-host privileges that I'm massively taking advantage of here, so sorry to jump in. But I was going to ask something about like survivorship bias, but that it should just sort of bias you towards the null. What about you alluded to this, like reverse causality, right? So it's not that the impaired fasting glucose is making your muscles worse. It's that your bad muscles are making your sugar messed up. Little harder to tell the cognitive story, like the reverse cognitive story. But what do you think about either reverse causality or just sort of a collinear, like they're both measures of something else going on, like it's just a confounded relationship for something we're not quite measuring?
Yeah, so within the whole of SWAN, which is where a lot of that racial ethnic diversity comes in, unfortunately, the physiologic measures only started to be captured at visit 12. So it's really, really hard to look at some of those kind of longitudinal trajectory changes. However, within Michigan SWAN, I think it would be actually quite interesting to look at joint trajectories of this this glucose metabolism with changes in grip strength over time, to see if there are different patterns that might emerge to show exactly that, to show that bidirectional relationship, and kind of get at a little more of, if one of those factors has kind of a bigger impact over the other, or if they're kind of co-equal partners in this functional decline.
Thanks so much.
Thank you.
Any other questions? Feel free to put them in the chat.
I mean, I can ask another one that sort of gets at your survivorship bias question, though. When you look at sort of those who were in your analytic cohort compared to those who started, like, do they look much healthier? Do they look healthier?
Yes, they do. And there's been a number of papers about right censorship in SWAN. The one that's coming to the top of my head is by Alexis Reeves. That was her dissertation work, was looking at right censorship bias within SWAN and how this might skew some of the findings. She's done a lot of work, in particular looking at inverse probability weighting and how does that impact the results. That being said, I think that while it is important, and it's kind of unfortunate that we're not able to capture those sickest individuals, I think one of the real strengths of SWAN is being able to really kind of get at that kind of population generalizable, what is kind of the experience for women, that I think is what we're capturing pretty well here, even though there is that potential survivorship bias for like the average woman. That's kind of who we have in SWAN now, is the average woman. So I still think there's definitely some meaningful implications that can come from that.
Super.
Did that answer
Thanks.
your question?
Yep, very much. And I do see stuff in the chat.
Yeah, it looks like that. Gary Martin asked, did you look at a degree of excess weight independently for cognition?
I did not, but that's one of the both for the physical functioning and for the cognitive, that's one of the sensitivity analyses we're going to do, looking at kind of stratifying that weight into the standard WHO BMI thresholds to see how that might impact our results.
And someone else is asking if you're able to bring up your imputation and deletion slide in the flow chart, but I don't know if you're able to do that from the other computer.
Yeah, that's going to take me probably like 6 or 7 minutes to get back into that
okay.
folder. I'm sorry.
But thank you anyway.
But you feel free to reach out to me if you want. I'm happy to share that with you after.
Thank you. Any last questions? Well, thank you very much, Dr. Leis. You had a lot of interest in this topic and in your talk. So thanks so much for joining us today.
Yeah, thank you so much again for having me.
Thanks so much.
Thanks.